Straight Smile Solutions, straightsmilesolutions.com, and I came up with this list of 5 questions to ask your child's dentist to determine if he or she or they really is an airway dentist. This is any type of general dentist or a pediatric dentist. And since most of the people on my channel are dentists already, these are 5 questions to ask yourself and your practice. You say you're an airway dentist. Are you? And patients are becoming much more aware, parents, and they know that a lot of dentists and orthodontists are not really airway ones, and they're looking for them. So here's how to make your practice more airway focused. Number 1, do you screen for SDB and oral habits in every child? I don't mean just looking yourself. I mean giving the parents an SDB form that they take home. They take a couple days before the appointment. You don't fill this out in the waiting room. And they fill it out and they observe their kid in the middle of the night. That's part of SDB. If you don't do that, it's not an SDB screening. Oral habits, I recommend the Fairest form. It's available online, look it up. If not, I can send it to you. It's not my form, but I'd be glad to send it to you. It's a malfunctional form, but it's ways of checking melon potty and tongue ties and stuff like that. So I say, can I see your paperwork? Because you should be willing to show your paperwork. Number 2, do you routinely refer to ENT when needed? What defines when needed? Obviously, those 2 forms would really help, but also taking cephs can help, and just general looking at the patient's bite, palate. There's so many different things that you can look at. Which ENTs do you recommend in my area who are like-minded? This is super critical. If you haven't already established relationships with like-minded ENTs who actually respect dentists, then you need to. That may take some time to find the right people. Number 3, do you have a certified OMT on your team? Better bonus if you have it on your team. There's way more success, but you can also work with a virtual one. I have 2 virtual ones we work with in our offices, just because we haven't really had a hygienist who wants to be an OMT yet, not who is willing to put in the work, obviously it's one thing if you pay for them to do it, but it's another thing if they actually really want to do it. But I work with a lot of practices who do have an OMT on their team, and they do a lot of myo, and they don't charge a ridiculous fee for it either. They kind of bundle it into their ortho. Maybe it's a little bit more, but it's definitely a part of the treatment, but it's not a whole different fee, which can help accept treatment a little bit more. Number 4, do you refer out or treat orthodontics in-house? Or treat orthodontics in-house, one or the other, refer out or do it yourself, routinely before the age of 7. The reason why I don't love the 7-up is 7-up turns into 8-9, basically, by the time it actually happens. And a lot of times that's too late, especially for SDB and myo and airway issues. It's already damaged by then. More than 60% of the growth is done by age 7. So, whatever growth you have left can't be influenced to really make that much of a change if you wait till 7. So you got to catch things earlier. I'm not saying you're going to do treatment, but just putting them on watch, sending them to ENT, sending them to myo, maybe getting rid of habits, and TNA issues. Great question. What are signs of an ideal occlusion in a 7-year-old? You guys should be able to, this is a great party trick, you can look it up. I have a whole video on that, but obviously we want the upper teeth to fit over the lower teeth, almost like a lid on a box, like a nice Christmas gift, lid on the box, They should overlap it a little bit. You should be able to see lower teeth, but you shouldn't be able to see all the lower teeth, but you should be able to see more than half of the lower teeth, when they bite down. We want to see gaps in between every single one of those front teeth, about a millimeter. Total of 6 millimeters per arch of spacing is good. Crowding is really bad, and perfect teeth are also quite bad. 100% chance the child will have crowding if there is perfect teeth in a 7-year-old, or even in a 2 or a 3 or a 4. Anyone who has all their teeth in 18 months, there should always be gaps. There should always be lower teeth showing when they bite down, but not all the lower teeth showing, just half or less, somewhere between 10, 20, 30, 40% is perfect. The lower teeth shouldn't bang up against the upper teeth, but there also shouldn't be a big space between the lower and upper teeth, if that makes sense. So all these things are signs of a really great occlusion. That just means that the child was fed properly as a baby, fed properly as a toddler, and didn't have any habits, or tongue ties or other things like that. Last one, do you provide or refer for tongue tie releases when needed? I feel like people get a little aggressive with this stuff now, but a lot of times it does need to be done. So I think learning to do it just judiciously is a good idea. All right, thanks so much.